Hello, I'm Dr. Jim Del Rosso, and I'm here in Las Vegas, Nevada. I am again the stunt double for Dr. Leon Kircik, filling in for him. He had another obligation, and I'm very happy to be doing this evening for the International Dermatology Education Foundation, a program called Your Biological Next Step. Next slide, please. So we want to thank our supporters for this evening, Ortho Dermatologics, that were kind enough to support this program. We have a great speaker tonight. I'll be getting to that in a moment. Next slide. So before we begin, if you're having any issues hearing with the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having any technical issues, just submit those in the questions pane on the right-handed side of your screen, on the right-hand side. At the end of the webinar, this is very important. A survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate if you fill this very short survey out. Within 1 to 2 days of the webinar, you will get a certificate of attendance, which will be emailed to you. Next slide. Please submit your questions using the questions pane on the right-hand side of the screen so that Dr. Merritt and I can get to them later on in the program. Next slide. We'll try to get to as many as we can. So Dr. Leon Kircik, he is the man behind the International Dermatology Education Foundation. It's a nonprofit organization that has a mission for raising awareness and improving dermatologic care, not only in the United States, but also all over the world, trying to focus also on underserved areas. And I'm filling in for Leon tonight. Next slide. So there's been a variety of previous educational sessions, and there are more coming up. We have a great program tonight. I think a very unique program by a great educator. Next slide. Also, stay up to date with the IDEF Educational Series webinars. You can go to these different sites. Please visit www.idefeducationseries.com to register for any of the upcoming educational events as they become available. Next slide. So it's a pleasure to introduce someone that I've known for some time. We both have practiced in Athens, Ohio. She's still practicing there, and that's Dr. Dawn Merritt, who has a very interesting background, which I wish we had more time to get into. But she is the founder and CEO of Oakview Dermatology, and she's the program director at the Ohio Health Dermatology Residency Program. I know many of her residents that have graduated, and they only say nice things about you, Dawn. So I'll turn it over to you, and thank you for being here.
That's them just being very nice, but thank you, Jim. I appreciate it. Well, thank you for having me tonight, and I'm excited to get to talk to you tonight about this topic, which is one that I enjoy and I find super interesting because a lot of my fellow colleagues are not actually utilizing this medication at this time. So today, we're actually going to talk about Siliq, or brodalumab, and we're going to talk about making Siliq your biological next step. And I apologize, we have a bit of a lag tonight, so I'm just going to wait because I don't want to click too far. So tonight, as you all know, this is a promotional program. It's being sponsored by Ortho Dermatologics, and I'm presenting on their behalf. We don't get to see me, I apologize. I wish I did too. And I'm giving this presentation as a compensated speaker for Ortho Dermatologics. And we're gonna go through all of the prescribing information, including some of the boxed warnings, and talk about that tonight. If you need the prescribing information, that'll be available to you at the end. There's actually a key you can click. So let's talk about psoriasis, because that's what we're here to talk about tonight. So I think we all know that psoriasis is very common. I mean, we're dermatologists and this is what we do, but I don't know that everyone realizes that psoriasis is actually the most prevalent autoimmune disease in the United States. And, you know, I don't really think of it that way, but it's super interesting. And more than 8 million people in the US have plaque psoriasis. That's about 2.4% of the population. And when we think about that, about 25% of the patients with psoriasis are actually going to be considered to have moderate to severe disease. And when we think about those patients who have moderate to severe disease, as opposed to the other patients with milder forms of psoriasis, we know that the moderate to severe disease has a greater impact on quality of life. And we're going to see a lot of the comorbidities that come along with that. And we'll talk about that in a minute. So unlike a lot of autoimmune diseases that are far more common in women, psoriasis really is equal. Men and women very similar across the two sexes. And when we think about prevalence by race, Caucasians are actually the highest prevalence for psoriasis of all races, although it's absolutely been described in almost all races. So when we talk about psoriasis, one of the things we know is that there's this increased prevalence of comorbidities in our patients. And the question is why? Well, there's a multitude of things. Well, there's a shared genetic pathway between psoriasis and some of these other comorbid conditions. There are some common immune mechanisms that can play a part. There's the treatment-related toxicities that we sometimes see. And there can also be that associated burden of the disease that has an impact on people from a psychological or mental health standpoint. So when we look at some of these comorbidities, I think, a lot of us are aware that from a cardiovascular risk standpoint, we see elevated risks in our psoriasis patients over non-psoriasis patients. And that's even true when we control for things like diabetes, smoking, and obesity. So this is something that I actually talk about often when I have a psoriasis patient who looks at me and says, I don't care, I don't want to treat. Because I think we now know enough to understand a little bit more about some of those things. And then we talk about inflammatory bowel disease. I think most of us are aware that Crohn's disease occurs at a much higher percentage in patients with psoriasis than the general population. We see some increased risk for cancers and type 2 diabetes. We know, I think all of us by our patient population, there's a higher incidence of obesity and a higher BMI. And then metabolic syndrome, we definitely see a higher incidence of metabolic syndrome in the patients. And then in the middle, we have depression. And I think while we think about this as being really sort of a direct reflection of having psoriasis, and we're going to look at some data I think that will support that idea, the other thing that's I think really interesting is we have found some specific loci, some specific pathologic pathways that actually make depression more common and more likely in our patients who have psoriasis. So it's not all about just having the disease and how it looks. There's actually a biologic mechanism. So when we look at our patients who have psoriasis and we think about them and their risk for depression, we know that our patients are twice as likely to become depressed as the general population. And I think we all see our patients and we see the drugs they're on. Depression is so common already in our society. So mental health comorbidities such as anxiety, depression, suicidal ideation and behavior, which we often just sort of refer to as SIB, these are all more prevalent in our patients, especially those with severe psoriasis. And so there was this large study that was done, which I think is pretty interesting. It was of more than 12,000 patients, and they surveyed them over 3 years. And of those patients, 16.5% of the patients with psoriasis actually met the criteria for a diagnosis of major depression. Now, Jim and I were talking earlier about the fact that in my prior life, before dermatology, I actually have a master's degree in counseling. And I will tell you, most of the people around us don't have major depression. They actually have some, they're a little sad or they're a little, maybe they have some other moods. But 16.5% of patients actually being diagnosable for major depression is pretty significant. And that's just all patients with psoriasis. And when we look at that. And so here's where we talk about this overlapping biologic mechanisms, which I think is fascinating. So that may have a lot to do with why we see this and why we see it to become more, more frequent. So today we're going to talk specifically about Silique and its use in moderate to severe plaque psoriasis. Now, normally I don't spend much time talking about the indication because I think we all know biologics are all for moderate to severe plaque psoriasis, or mostly, and they're for patients who are candidates for systemic therapy. But SELEEK has this added discussion, is that patients should have failed to respond, have lost response to a prior systemic therapy. Now that may be a biologic, that may be some other systemic therapy, but it's going to give us some interesting data that we're going to talk about as we go through this presentation because of how the studies were done. So I think you all know SELEEK is unique in that it has this boxed warning. And so the warning is for suicidal ideation and behavior, and that included completed suicides, which there was actually one that occurred in patients treated with SELEEK. And so prior to prescribing SELEEK, we have to, as providers, we have to weigh this potential risk and benefits with our patients who might have a history of depression or suicidal ideation and behavior. So it's something I screen for in all my psoriasis patients. So honestly, this isn't a whole lot different in my patients that I'm thinking about starting SELEEK. And so for patients with new or worsening suicidal ideation and behavior, those patients, obviously, you're going to refer out to a mental health professional as appropriate. And we're going to just advise our patients and caregivers to seek medical attention for any manifestations of any suicidal ideation or behavior and new onset or worsening depression, anxiety, or other mood changes. And then later in this program, we're going to talk more in depth about this risk evaluation and mitigation strategy, or REMS program for SELEEK, that every patient and provider who uses the drug will have to be a part of. But we'll go through it.
So Dawn, I have a question for you. So as you mentioned, this has that added statement about patients not responding or having difficulty with another treatment that they have used. Does that have to be a biologic agent? Could it be another type of systemic agent?
That's a great question. It could have been methotrexate.
Okay.
So the reality is your insurances are the ones who are going to be sticklers about that, because they're going to want to know what was the systemic that they failed. But it could be methotrexate or cyclosporin or acitretin, which I know most of us aren't using those entities anymore to treat psoriasis, but it doesn't have to be a biologic that they were on.
And so if you're gonna make that change before you start SELEEK, do you use a washout period? Does it matter what they've used before? You know, how do you approach that? Or do you just immediately go right over to SELEEK?
So I'm going to call that out, that this is obviously an off-label question in the sense that I don't know that Orthodermatologics has any data around this topic. So I'm just going to tell you what I would do personally. And in my practice, I'm not going to do a washout. So there's usually going to be a washout, because ultimately it's going to take me time to get the drug approved. So often there's a natural washout that happens in my practice, but for me, as soon as I have drug, my patients want to get better, I'm usually going to go ahead and dose them. So we can talk more about that later if somebody wants, but yeah, great question. So when we think about the biologic treatments that are available right now, there's a number of different targets in that inflammatory pathway. And that really describes all these different classes of medications. And, you know, Jim and I practiced before any of these were available, and we're very familiar with doing methotrexate, cyclosporin, and acitretin, because that was all we had for a long, long time. It is so wonderful for our patients that now we can talk about TNFs, IL-12/23, IL-23, IL-17A, the newest IL-17A and F, and then of course what we're talking about tonight, IL-17A receptor blocker. So that is SELEEK. So how is that different? Well, when we think about IL-17s, we talk about IL-17A a lot because that was what we first all sort of became familiar with. But there's actually 5 cytokines. There's A, C, E, F, and the AF dimer. And so when we look at psoriasis patients, all of these different cytokines, these IL-17 types, are elevated in psoriasis. But A, C, and F, you can see are elevated, 28 to 33 times what the general population. And so these are definite targets for our patients who have psoriasis. So SELEEK is really the first, and it is still the only IL-17A receptor blocker that we have. And so what it does is it essentially binds to that receptor, and it blocks all of those IL-17 cytokines from being able to interact. And when we do that, what does that mean? Well, that decreases inflammation, primarily by stopping that IL-17 cell or that, keratinocyte from being able to then produce pro-inflammatory cytokines that keep that sort of pathway and that whole inflammatory cascade going. So here, we have a little more information on the mechanism of action. And what we see is that SLEEK is a human monoclonal IgG2 antibody that obviously we already said binds to the IL-17 receptor A, and it does so with high affinity. So once it binds, it kind of hangs on there, and it blocks the interaction with a bunch of those cytokines rather than with just one or two. And so one of the things we're going to talk about in our next slide is the fact that there are thousands of aberrantly expressed genes in psoriatic lesional skin. And there was a really interesting study that actually showed that brodalumab, or SLEEK, was able to normalize that significantly within just 2 weeks of the initial treatment. And so when we look at this is from that study. And so this was a 2014 study. And what they did is they took biopsies from 25 patients who had moderate to severe plaque psoriasis, and they did baseline, week 2 after having initiated with brodalumab or SLEEK, and then week 6. And they analyzed that for both histology and RNA expression. And so let me orient you. Green are those previously identified sequences that were green is underexpressed, red is overexpressed, and we see this is compared to non-lesional skin. They're huge. And then when we look at what happened in 2 weeks, we see already so many of those gene sequences have actually are no longer under or overexpressed. And so what does this mean for you and I? I can't say that we know exactly how this impacts every single patient, but I think what we see is there's definitely some significant things happening once we give drug, and it happens as soon as 2 weeks. So starting with some safety information, it's kind of speckled throughout the presentation. From a contraindication standpoint, obviously we're not going to use SLEEK like the other IL-17s in our patients with Crohn's disease, because we know it may worsen or certainly not going to help our patients who have underlying Crohn's disease. And then you're also not going to want to use it in a patient who had a prior, significant hypersensitivity reaction. I always love that we have to put that in there, but important to touch on. And then that REMS program that we talked about. So every patient, provider, and pharmacist will be involved in the REMS program. But if you haven't done it before, when we get later in the presentation, I'm actually going to talk to you about what this looks like. It is so different than the other REMS program that we're all familiar with for isotretinoin. Completely different. So let's talk about some of the data. So these are the SLEEK pivotal clinical trials. So we had Imagine 1, 2, and 3. So in Imagine 1, there was just SLEEK versus placebo. And Imagine 2 and 3, we had SLEEK, placebo, and then we had an active comparator of Stelara. And so that's going to help give us some information as we go on that'll give you something that you kind of may already have an idea about that I think is a nice reference for us, both from a safety standpoint and an efficacy standpoint. So the co-primary endpoints in Imagine 1 was a PASI 75 at week 12 and an SPGA of 0 or 1 at week 12, and then you had to have that 2-point change. And then in Imagine 2 and 3, we had the same co-primary endpoints versus placebo, but versus Stelara, we were looking at a PASI 100 at week 12, and then some key secondary endpoints of a PASI 100 versus placebo and a PASI 75 versus Stelara. So when we look at this data, now remember, there were about 4,700 patients in these clinical trials. So here, looking across it, we get to look at what that PASI 100 data looks like at week 12. So in Imagine 1, remember, no comparator with Stelara. So we just have SLEEK versus placebo. But we see 42% of patients on SLEEK in that arm of the trial were at PASI 100 at week 12. And in Imagine 2 and 3, we had that comparator of Stelara. So we see 44% for SLEEK, 22% for Stelara in Imagine 2, 37% for SLEEK, and 19% for Stelara in Imagine 3. So almost double the number of patients achieving a PASI 100 at week 12 on Siliq versus those in the Stelara arm of the same study. So here we can look at PASI 90 results. And when we look at week 12, we have we have a significant number of patients, somewhere around 70% of patients achieving that PASI 90 response at week 12. But what's really key here is if we look at week 2, we already see a significant number of patients compared to placebo here. This is a placebo comparison, already achieving a PASI 90 as early as week 2, which kind of goes hand in hand with that data we looked at earlier. And so there were 5% of the patients on Siliq and none of the patients in the placebo trial with a PASI 90 at week 2. So what about the time to achieve clearance? And here what we can see is we can actually look at, we're looking obviously for total clearance of PASI 100, and this comes out of that Imagine 2, the one of the arms that had a Siliq comparator to Stelara, although we are not looking at this in comparison to Stelara. So this is Siliq to placebo. And what we see is we see that nice separation relatively early. And then here, 44% of the patients achieving a complete PASI 100 at week 12. So you can kind of look at that graph, and this is what our patients want. You know, if they start to see an improvement relatively early in their therapy, that's when they get excited, and we don't get as many phone calls because they see things happening. I typically don't see my patients back until 12 weeks because I want to give them time to have all of this happen before they come in. And these patients obviously are seeing some changes. So what about adverse reactions? So here we're looking at placebo, Siliq, and Stelara, and we're looking at those things that happen 1% or more in the Siliq arm as compared to placebo over that first 12 weeks. And so the most common things were, you know, I'm not going to read this list to you. You can all see it to the left. But I think what's important as you look at the numbers is that as we look at this, you know, like injection site reactions, it was actually less than what we would see from Stelara and very similar to what we saw in placebo. And for the rest of these, they were, you know, numerically slightly higher in many cases, obviously, than placebo, but very similar to what we saw with the Stelara arm. And so overall, I think that is data that I know for me, I have appreciated getting to see and share with my patients. So now let's talk about patients who have prior biologic failures, because remember, we said all of these patients had to be on something systemic prior to going to Siliq. So a lot of them in our practices will probably be prior biologics. So we want to know what that looks like. How are our patients going to do? Are they going to have these same types of results if they're not bio-naive? And what happens when we recapture? So here on the left-hand side, we have a post hoc analysis that was actually results after week 12. And here this was Siliq rescue after anti-TNF failure in patients. And so what we find, failure here was a patient who failed to achieve a PASI 75 or had a relapse. And what we see is 62, almost 63% of patients still achieving a PASI 90 once transitioned to Siliq for 12 weeks, and 32% of patients achieving a PASI 100. Well, what about the patients transitioning from IL-12/23? And this actually came out of the Siliq trials because patients in the trial, those that were on IL-12/23 in the form of Stelara, they then got transitioned over to Siliq so we could see what would happen. And what we find is those patients who were Stelara failures, 58% of them PASI 90 on Siliq, 36% of them PASI 100 on Siliq. So we're still seeing really robust reactions and outcomes for these patients. Now, probably the biggest question I get is what about a patient who's been on a prior IL-17A? Because obviously we're talking about that same cytokine family. And so here, these are results at week 16. So it's a little different because this didn't come out of the pivotal trials. So this is at week 16 after Siliq rescue of an IL-17A failure patient. What I think is interesting, these were both izokizumab and secukinumab patients, and 10% of the patients in this specific trial had actually been on both izokizumab and secukinumab. And what we found was 44% of those patients still achieved a PASI 90 after failure with a prior IL-17, and 28% getting to a PASI 100 when we use the receptor blocker versus one of the IL-17A specific drugs. So I think the take home is, when we look at patients who have prior biologic failures, in general, we think of them as being harder to treat. But across the board, what you see here is really robust positive outcomes, despite having those prior biologic failures. So here's another way to look at some of this. So this is stratified results after 26 weeks of Siliq treatment on these patients with prior biologic failure. So this study came out of Canada. There were 245 patients enrolled, 202 that finished. So that's what we see at the bottom. And here's what we're seeing is, how did they do? And so as you would anticipate, when we're looking at, on the left, a PASI 90, gray are the anti-TNF failures. And then from the gray, so sort of going right to left, we go anti-TNF, anti-12/23, IL-23, IL-17. And so like IL-23, which is the medium shade of green, 61% of those patients who failed on an IL-23 went on to have a PASI 90 at week 26 with Siliq. Well, what about a PASI 100? Well, 46% of the IL-23 patients who were a failure on IL-23 went on to have a PASI 100 when they were transitioned over to Siliq and given 26 weeks. So I think the take home here is, we really see very robust outcome data for patients, even those harder to treat patients who have failed other biologics. And this includes a lot of the ones that you and I use every day in our office. So these are not just old drugs. This is IL-17s and IL-23s. So we get to see that data and what we can expect. Now, what happens if we have a patient who's bio-naive? So maybe you have a patient who you had on methotrexate years ago and they pop back up because they didn't do well, and they're like, do you have anything else? And you say, okay, I want to put you on Siliq. You've never been on a biologic. Well, what we find is 86% of those bio-naive patients going to get a PASI 75. Well, when we compare it to bio-failure patients, it's really not that different, 81%. What about a PASI 100? 42% of bio-naive, and of course, they tend to be a little easier to treat, but 32% of bio-failures. So I think what's really interesting is, there wasn't a big separation here when we separated out with this ad hoc analysis of patients who had been on drug, prior biologics or not. They looked very similar. Now, what about recapture? Because as much as I would love to believe that all our patients are super compliant, and once we put them on drug, they do exactly what we tell them and they never go off drug. We know that A, patients don't do that. B, we know that insurance causes trouble in our offices and patients end up off drug because of insurance changes, lapses, all sorts of things. And then sometimes we have reasons, patients having surgery and their surgeon says, I want you off of everything. Often I don't even know about it until well after the case, the patient comes back and they're a mess. And so I want to know, my patient who is doing really well and that surgeon stopped my drug without talking to me, what can I expect? Well, 95% of the patients who had a PASI 100 before are going to recapture that PASI 100 again after 24 weeks of therapy. And 97% of my PASI 90 patients going to see the same PASI 90 after 24 weeks. So we're seeing really nice recapture data for our patients who then go back on drug. The other question that comes up is, what is the median time to relapse? Now here we're talking about a relapse to PGA of 3, okay? So a pretty significant disease. And what we found is the median time to return to that was 56 days, but the average time was 75 days. And the average being so much higher than the median, what that tells me is there were a number of patients that went really long, because obviously we know there are some people who didn't go quite as long, but that's pretty good data that we can all use when we're managing our day-to-day stuff. So now we're going to talk about patient-reported outcomes, and this is everything else we've talked about so far is what you and I see and how we visualize the patient. I think patient-reported outcomes, or PROs, are important to talk about because this is how the patient feels. So this was a post hoc analysis of phase 3 clinical trials. So imagine 1, 2, and 3. And what they wanted to know was what percentage of those patients had a DLQI of 0 or 1. So just a little reminder, DLQI goes 0 to 30. A 0 or 1 from a severity standpoint in DLQI are those daily, when we're looking at daily activities and how the patients feel, that dermatology life quality index. What we know is that a 0 or 1 is equivalent to my disease doesn't impact me at all. And so that's where we want all of our patients to get, to a place where the psoriasis is not a big impact on their life. And what we find is 56% in Imagine 1, 61% Imagine 2, 59% Imagine 3. So nearly 60% of all patients across the clinical trials got to that place where psoriasis really just didn't impact their daily living at all by week 12. Pretty significant. And you could see that compared to Stelara, which I think was important. So here we're looking at patient-reported outcomes in patients with prior biologic failures. So we show this because the question is, does it go down? Not significantly. I mean, if we go back, we were all close to 60%, here 56%. So what we find is basically, regardless of prior use or not, patients really, nearly 6 out of 10 patients are going to get to this DLQI of 0 or 1 at week 12. Now, I really like looking at this because this is how I think, and this just sort of supports what I thought made sense. And so here we're looking at this DLQI of 0 or 1 stratified based on the PASI response that we see. And it's exactly as you would expect. A PASI 100, 80% of patients said their psoriasis impacted them at a 0 or 1. Not at all, really. 63% of those in that 90 to 100 range, and PASI 75 to 90, 43%. But that's as I would expect. The more they see every day, the more they think about it, the more it's probably going to impact their life. And so I think that was sort of intuitive, but really nice to have data to show that it actually is what happens. So a little more safety information. We do know there's some cases of serious hypersensitivity reaction, including anaphylaxis, that have been reported. So obviously keep your eyes out for that. And like all biologics, Silique may increase the risk of infections. And so it's something that you need to consider when deciding to put your patient on a biologic of any type, but here specifically Silique. Something we have to think about and consider and weigh those benefits and options with our patients. So here we're talking about TB. So we all know we have to do a baseline TB screening on all of our patients before they go on a biologic for psoriasis. So we do need to do that. And that's important that we do that baseline TB and we continue to monitor throughout. The other thing is there have been some eczematous eruptions in marketing studies that have been reported. And so when that actually happened was variable. Sometimes it was just days after starting Silique and sometimes it was months after the first dose. But something also to be aware of, and if you see it, you might know that, maybe that was somehow related and something that as you treat, you would probably want to consider. Now, I love this section of this PowerPoint because I think this really drives home what our patients are seeing. Many of us don't live with any chronic skin diseases. And so we don't necessarily, we see our patients, but I think it's helpful to sort of see what this looks like when they're at home. So here is a patient at baseline. They had a 16.5% BSA, so very large, PASI of 15.9, and we see them at week 12, they're at a PASI 90, and then by week 52, that PASI 100. And I think for these patients, what a difference can make. It's amazing to me that patients still come who have been living with disease like this for extended periods of time. Here is a clinical study patient who came in, and this was them before therapy, obviously. Their BSA was 56, which is huge, PASI of 40.6, again, just crazy. Look how red and inflamed and scaly that is. At 12 weeks, wow, 98% PASI response, mean PASI response. Pretty significant, and then 100% response at 52 weeks. I don't know this patient, but I can only imagine, having seen my own, that that was life-changing for this patient. Here's another patient at baseline, a BSA of 23, dropped to a 4 with a 98% PASI response at week 12, and again, clear at 52 weeks. And then these pictures were actually shared. These are actually a real life patient case that was shared post-marketing. And this is just crazy. I mean, I think we've all seen at least one or two of these patients in our time, maybe more if you've been doing this longer. This patient had an 80% BSA at baseline. And so all three of these photos are from their baseline. I cannot imagine functioning like this. And here's this patient 12 weeks later. You know, the first time I saw this, I was just, you know, you just can't imagine. I have a patient who's much like this. And, you know, that patient still to this day, when they come in, I get a hug. I think it's just really such a dramatic change. And here, this patient said they had a PASI 100 response in just 12 weeks. So we're going to talk about some additional data. And what is this? This additional data is looking at scalp and nails, because I think most of us know and think of these areas as being slightly harder to treat. So here on the left, we have scalp data. And so we're looking for a PSSI of 75 or a PSSI of 100. And here we're compared to placebo. So at week 12, we saw 89% of patients achieving a scalp clearance of 75, like a PASI 75 of the scalp. And when we look for complete clearance of the scalp, 63% of patients achieving that at week 12. Now on the right, we're looking at nail data. And I'm going to orient you a little bit because the colors have changed what they represent a bit. So Silique is in dark green, and actually Stelara is in the light Kelly green. And so here we can see these patients looking for a NAPSI 0. So we're looking for completely normal nails. And we're looking at them at week 12, 24, 36, and 52. Now, all of these patients had at least a 6 or higher NAPSI score at baseline. And so that was pretty significant. The average NAPSI was a 9.6. So these are pretty significant nail changes in the patients that were in this. And what we see is across all time points, we see obviously very significant differences between Silique and Stelara, but we see at week 52, 64% of the Silique patients with completely clear nails. And that, you know, obviously a smaller number at earlier time points because this takes time, as we all know. So what about our patients who are obese? Now, one of the things we sometimes worry about is that patients who are heavier are going to have not quite the same response. So on the left side of the PASI 100 slide, what we see is brodalumab, and the light green are your BMI patients who are less than 30 kilograms, and your BMI greater than 30 on the dark green. And so I think what's key when we look at brodalumab or Silique is, while there was a difference, 54% versus 49, it wasn't very significant. When we look at the ustekinumab or the Stelara patients, we see a much bigger step off. And keep in mind, the patients who are on Stelara were doing the dose based on their weight. So for those of you who might not actually get to prescribe, maybe you're a resident and you haven't prescribed Stelara much, there are different doses for different weights. So there's 2 doses, and if you're heavier, you go to the heavier dose, and that was utilized here. So when we look at a PASI 100 response and we look at it based on weight, again, very similar. Here, the difference is we're looking at 52 weeks. So the initial slide on the initial graph on the left is 12 weeks. When we give patients enough time, our heavier patients on Stelara do catch up. But again, very similar responses with both with Silique across both groups. So a little more safety data. Crohn's disease, we already talked about higher incidence in patients with psoriasis, but I will say in clinical trials which excluded Crohn's patients, there was one Silique patient who was withdrawn after developing Crohn's disease. So discontinue if you have a patient who develops Crohn's during the, during usage. Like all biologics, you're going to want to avoid use of live vaccines in your patients on drug. And then the adverse reactions, we already sort of talked about them, so they're here for you to see. These are all those adverse reactions that occurred more than 1% higher than those on placebo. So let's talk about long-term maintenance and safety. So here we have our PASI 100 responders at week 12. And the question is, if they were a PASI 100 responder at week 12, did they maintain to week 52? And what we see is 72% of patients were able to maintain that out to 1 year. And so pretty significant percentage of patients able to maintain that over time. Here we have a post hoc analysis from Imagine-1 with an open label extension, and we can actually look at what happens with our PASI 100 out to week 108. Now, what's interesting is studies were actually discontinued by Amgen, and patients stopped treatment between weeks 96 and 108, but they continued to get reevaluated and monitored. So remember, Siliq is dosed every 2 weeks for maintenance. So here they weren't getting any drug after week 96, and we still see a nice plateau, 68.5% of patients with that total PASI 100 clearance at the end of week 108. And you can see the rapid rise, how quickly patients actually were able to obtain that, and then how they maintained that out over time. So what about looking at some post-marketing safety data? So this data was actually presented last year at Fall Clinical. For those of you headed out to Fall Clinical tomorrow, I know I'll be on my airplane bright and early tomorrow morning. Let me orient you a bit. So the total cases were the total cases of these adverse events seen in the original 4-year post-marketing safety data. And then the new cases are listed in the middle, and those were the cases that occurred in year 5. And then we have sort of a crude adverse event reporting rate per 100 patients. And so these are all those adverse events we've already talked about earlier in this slide deck. And with the, at the bottom, we also have tinea infections. And what you see is no new cases in year 5 and no crude reporting rate per 100 patients. And when we look at that rate of these throughout those patients per 100 patients, again, very low rates of these common adverse events. Now, what about these post marketing safety data looking at clinical events of special interest? And these are those things that I think we're talking about a lot more because of some of the newer oral drugs that are on the market. So we're back to talking about adjudicated MACE, malignancies to a greater degree. And then of course, we also have inflammatory bowel disease and suicide completion on here, as you would expect, as well as serious infection. And so when we look at this data and we compare it to some of the SOLAR data, things like serious infection are actually less, and depression was actually less than what was seen in the SOLAR data, which SOLAR data is for all biologics. And so I think when you look at these numbers, they're actually, remember, they're reported per 100 patients. These numbers are very low, and most importantly, no suicides during that 5-year post-marketing study. So how do you start? So maybe I've convinced you that the efficacy is something you want to try in your patients, especially if maybe they failed something else and you want to get it the first time with them after that. So let's talk about that. So dosing. So when you start treatment, all the injections are 210 milligrams in 1.5 mLs. And these are single dose pre-filled syringes, okay? And so each box is 2 of these. So in the beginning, you're gonna do a dose at 0, 1, and 2. So once weekly, that's your loading dose for the first 3 injections. And then it's every 2 weeks thereafter. Pretty straightforward, pretty simple. What about storage and handling? Ideally, keep them in the refrigerator for long-term storage. It is recommended to keep the injections in the original carton to protect them from light because, as we said, they're a pre-filled syringe, so they don't have all that plastic covering them like you would see in a pen. When necessary, and I like to point this out because this comes up at least once or twice a year, I get a patient who calls me. So Orthodermatologics has come out and said that once you take that syringe out and lay it on the counter, which I always recommend doing before injection so that it comes up to room temperature, when you do that, it can actually stay out of the refrigerator for up to 14 days as long as it's protected from light and sources of heat. So every now and then I have a patient, like during the hurricanes, maybe you have a patient who lost the refrigeration and they're like, well, what do I do? Well, as long as the temperature didn't get really above about 77 degrees Fahrenheit, they can use that, for up to 14 days. But once it's been out at room temperature, you shouldn't put it back in the refrigerator. Don't freeze them, don't shake them. And then let's talk about REMS, because I think everyone's like, okay, well, what is that? How do I do it? Does it look like what I do for iPledge with isotretinoin? The answer is no, and I'll explain why. So the goal of the SLEEK REMS program is to mitigate the potential risk of suicidal ideation and behavior. And how are we going to do that? Well, we're going to make sure that prescribers are educated about the potential risk of suicidal ideation and behavior that was observed with SLEEK therapy, but also ensuring the patients are informed. And so that's important too. So what does that mean? Well, you're going to get certified. That's actually really simple. It is a one-time enrollment form. Can be done on paper. Nowadays, most of the reps can do this for you electronically. It's really simple. It's literally as simple as reading a statement and signing on the iPad. You guys do those sorts of things every day to get samples in your office, things like that. That is the extent of what you, the prescriber, has to do. From a patient education and enrollment standpoint, it is on you and I to make sure that we talk to our patient. So I have this conversation with every patient, and then the patient has to sign and submit one time the SLEEK REMS patient prescriber agreement form, and this is what these look like. So here is the prescriber enrollment form, and if you have your rep do it, usually they fill it out for you because it's just your basic information that they have, and then you sign it after you read that prescriber agreement. And then your patients, same thing. We have these in EMA, and so ours actually pre-populate with their information, so it's actually very simple. I have my patient read it over, and then the patient signs it. And then the patient gets the little card that has some information, including the National Suicide Prevention Hotline phone number that we are required to give them. And that is about it. That's about as simple as it is. So what about coverage? Orthodermatologic's done a really nice job. So for our patients who have insurance approval, they can get the drug for about $0 per month. So most patients are pretty happy with that. But what if your patient gets denied? Well, Orthodermatologics has extended their bridge program. It used to be 1 year, and they've actually extended to 2 years, which I want to say thank you, thank you, thank you, because sometimes 1 year is not enough to work with insurance plans to get them to agree. And it is $50 if commercial insurance says no. So the reality is, I think most of my patients can afford this, and that's $50 per month, even if they have a straight denial. So when we look back through the clinical trials and the efficacy, just a reminder, almost 5 out of 10 people were 90% clear at week 2. Almost 9 out of 10 people were 50% clear when we look at them, a little bit later. And then more than 8 of 10 people were 75% clear, and more than 4 out of 10, 100% clear at 12 weeks or 3 months. When we look at 1 year of those PASI 100 responders, we saw that about 7 out of 10 or 72% of patients, if you remember, were able to maintain that complete clearance. And then at 2 years, we saw that more than 7 out of 10 patients who continued treatment stayed clear. So really good, robust efficacy data. Remember, blocks only drug blocking all the key cytokines. We saw a lot of these patients achieving PASI 100, and it even works in our patients with prior biologic therapy. So with that, I thank you, and we'll open it up for any questions.
I see a few questions coming in here, and one that I think is very practical. In fact, I had it myself. So you have a patient, let's say a 44-year-old, doesn't matter if it's a male or female, right? And you're talking to them, and you approach them and you talk to them about this risk evaluation and mitigation strategy program, which I'm glad you mentioned the iPledge, because everybody thinks that that's only for pregnancy prevention, but it has to do with a specific drug and what the risk might be for that drug. And in this case with Salik, it's the suicidal concern, ideation, and behavior. Let's say that patient tells you, well, you know, back when I was in college or in my early 20s, I hit a pretty low point in my life and I thought about committing myself and I tried to attempt suicide one time. And I'm past that. I feel much better now. I got help. It's been over 20 years ago. What do you do in that situation?
So, we all practice medicine differently. So let me say that first. And second, I'm going to be very clear. This is what I personally, Dawn Merritt, would do, not what orthodermatologists would tell me to say. This is purely what I would do. In my practice, I feel like patients get to make decisions. I am there to guide them. I'm not there to tell them what to do. So what I talk to patients about, as I said here, let's talk about the clinical trial data. Let's talk about what this looks like. And then I essentially leave it up to them. I have had patients like that. And, for a lot of them, they'll look at me and say, I haven't had an issue in, in your case, 20 years. I am willing to give this a shot. And if I start feeling poopy, I know what that feels like, and I'm just going to stop. And that is, from my standpoint, if that's the response, then I am willing to work with them. And we just talk about what happens if they were to have some change. At the same time, if they look at me and say, ooh, that makes me nervous, I'd say, okay, then this isn't the drug for you. Let's move on. And we talk about something else. So at the end of the day, I feel like it's our job to really help patients understand risk and what does that mean for them in their life, and then let them make the decision.
Okay. So another question has to do with what about if it's a patient, because there's a tendency, we see patients over a long period of time and they know us and we feel like we know them, but we don't always really know exactly what's going on every day of their life. Do you still make sure you're addressing this risk the same with everybody and don't make assumptions that, oh, I think so-and-so's okay, right? So how do you do that?
100%. I mean, it's like all those memes. You have no idea what's really going on inside. And, it could be your best friend, and they might not tell you unless you present it in a situation where it might have an impact on their own life. So absolutely, I have the benefit. It's kind of funny that I have this past history, and I don't know that that was actually relevant. In fact, I'm not sure that orthodermatologists knew that I had this prior history as a mental health counselor before I went to medical school. But I will tell you, having talked with lots of patients, often we don't know. Sometimes the people who put on the prettiest smile and seem the happiest are some of the people struggling with depression. So I think it's most important to normalize it, have a candid discussion. If I'm uncomfortable, they're going to be uncomfortable. So I usually just say, we need to talk about something related to this drug that's a little different. It has this box warning. Is something that you currently deal with or have ever dealt with? Or is this something you're concerned about? And you just open the dialogue. And I think often when you do that, you will often learn things sometimes that, you didn't expect. And sometimes, like I said, you might have a patient who says, I'm not worried about that. Let's move forward. And that's great.
So I think that's really important. And, there's so much focus on it because Salik has the REMS program, but patients with psoriasis, with chronic diseases, we're finding out with hidradenitis suppurativa, atopic dermatitis, all these other diseases that we're getting so much information on, regardless of what therapy they're on. This is an important thing to pay attention to with all these patients. Even psoriasis, just as a disease, has a higher risk of suicidal ideation and behavior. So I think it's a good learning experience for all of us, not only with Salik, but across the board. How do you feel about that?
I think, I agree 100%. I think as dermatologists, our visits are relatively short. And I think some of these things, it's helped us. All these things help us to become better clinicians because we have conversations that maybe we otherwise wouldn't have. But when you look at, for me, it's absolutely worth it to have these conversations because especially when you have some of these really hard to treat patients, what we all want is to be able to get them to the place they come in and they go, oh my gosh, this is what I've been waiting for. And that's what You know, that's the high that I think we all sort of want. We want to fix things. And so this is a drug that I really enjoy using because I get to have more of those events.
Yeah, and because of the REMS program, I think sometimes it's forgotten, but it was good to get a good review and to show really what this therapy brings to the table. I want to thank you so much for your time tonight. It's always great seeing you. It's always great listening to you. I do want to remind everyone to just thank them, and also to thank Ortho Dermatologics for providing the support for this program. The detail and the explanations were excellent and very practical. And next week, we have another program. I am actually going to be speaking next week. So if you've not had enough of me tonight, you can come back tomorrow. But you're probably all thinking, I wish it was Dr. Merritt again, but it's going to be me. I want to thank everyone. And Dawn, have a safe trip tomorrow. I'll see you in Las Vegas and hopefully see others, right? Thank you very much. And thank you, Ortho Dermatologics. Good night.
Bye, guys.
Bye-bye.